Now let's examine two intraoperative strategies that try to compensate for flexion space laxity when the PCL is excised or injured. Strategy 1 is to reduce the native posterior slope, which reduces the risk of flexion space anterior-posterior tibial-femoral instability. This is a schematic that shows how to recut the tibial resection in order to reduce the native posterior slope. So here we've made a posterior slope cut that matches that of the native knee at 76 degrees. And now we've gone ahead and recut it such that the new slope is 82 degrees. And then when we place the tibial component on, it tends, as you can see, to tighten the flexion space posteriorly, and this then reduces the risk of flexion space instability. So in this case, we changed the slope 6 degrees to compensate for sort of a large 5 millimeter increase in flexion laxity from excision of the PCL. However, you have to understand this requires a thick insert, and you may need to do a possible augmentation of the base plate or use a short stem extension. The other option to reduce the slope is to bone graft the posterior third of the tibial resection to reduce the native posterior slope. And this is a great option when you're already at a 12 or 13 millimeter insert from your first cut. So here we'll go back, we'll show the native cut initially. We decide we want to reduce it. So what we can do is put a piece of bone which we cut from the posterior third of the tibial resection that we removed and use that as bone graft on the posterior third of the tibia. And then we can reduce the slope and impact the triotibial base plate until we achieve the desired slope that we want. And in this fashion, we can then go ahead and reduce the slope and tighten the laxity of the flexion space without going and using thicker polyethylene and getting into the use of revision components. So this is a very good strategy. And if we look at post-op radiographs, you can see that in this coronal view, you can see that the insert is a little bit on the thicker side. This was the posterior slope of the contralateral knee at 89 degrees, and then we went ahead and cut a piece of bone graft from the tibial resection that we removed from the tibia, placed it on the posterior third, and then we impacted the base plate, causing a change in slope from 89 to 94 degrees, and this tightened the flexion space and reduced the risk of flexion space laxity. So the second strategy is to resect a little bit more bone from the distal femur and then use a thicker insert. This can also reduce the flexion space AP laxity. So let's look at this schematic that shows how this recut is done, and it enables us to use a little thicker insert to tighten the flexion space without losing knee extension. So here we've made our distal resection, and we'll go ahead and cut 2 millimeters more off, and there you can see the tibial insert. And now we'll go ahead and put the femoral component on, and you can see the gap between the femoral component and the tibial insert because the PCL was cut. Now, when we proximalize the femoral component or elevate the joint line, then we can use a thicker insert and tighten the flexion space. So this is a pretty good strategy, but it has the disadvantage that it elevates the distal femoral joint line, which violates kinematic alignment principles and can cause some mild mid-flexion laxity according to Thomas Lukic and Johann Bellemann's work. So the other thing you have to do, whether you're adjusting the slope from either adjusting the tibial resection or bone grafting or cutting more off the distal femur, you have to verify that the tibial insert does not subluxate posterior on the femoral component during a posterior drawer test. So we've got these two femoral models. You can see the flexion gap is lax on the schematic on the left and tight on the right. And when you do a posterior drawer with the leg lifted off the table, if you see this type of subluxation and the flexion space is too lax, you need to either add constraint or use one of the other methods for tightening the flexion gap.